In this chapter we will be scanning the wrist transducer positions, and we will start with the first transducer position, which is the first extensor compartment. This compartment contains the extensor pollicis brevis and the abductor pollicis longus tendon. The patient is sitting on the other side of the table and the hand is placed on the table. And then the hand is supinated into this position. The transducer is placed on top of the first compartment, extensor compartment, and if you're not sure where it is, then you can find several landmarks. At the radius you can find the radial tuberosity or lissus tubercle, that's a synonym. This lissus tubercle indicates roughly where to place the transducer. Another thing you can use as a landmark is actually by extending the thumb and then following the tendon into the first compartment. So I will place the transducer in short axis, transverse, on top of this. Yeah, relax. What we see actually is the radius. With on top we can see the abductor pollicis longus and the extensor pollicis brevis. And of course they also have a thin tendon sheet which can be observed here. So if we follow the tendons to proximal, then you can see that these tendons will move superficially to two other tendons, which is actually the extensor carpi radialis brevis and longus. And you will see that the tendons of the first compartment, the extensor pollicis brevis and abductor pollicis longus, will transform in a muscle. So you can see the hypoechoic muscle belly with actually the first fibers of the extensor compartment 1. So this is again the first compartment back to distal, and beautifully we can see here the abductor pollicis longus and extensor pollicis brevis. Yeah? So always follow first compartment also to proximal, because this is a very famous spot where you can have a impingement or a friction actually, which is called the intersection syndrome, a friction between the tendons of compartment 1 and compartment 2. The second transducer position of the wrist protocol is scanning the transverse compartment number 2, and that is the extensor carpi radialis brevis and the extensor carpi radialis longus tendons. The patient is again sitting on the other side of the table of the sonographer, and the hand is placed with the palmar side on top of the table. Palpating the lissus tubercle or the radial tuberosity, the transducer is placed on top of that, like this. What we see now in the middle of the screen with the arrow indicating, that is actually lissus tubercle. If we shift or sweep the transducer to the radial side, yeah, then you will see that these are the extensor carpi radialis longus and the extensor carpi radialis brevis tendons within their tendon sheet. So this is the tendon sheet. So keep the tendon hyperechoic and follow the tendon to proximal. And this is again this famous position which can cause a certain friction a little bit to proximal, where there is an intersection, a friction possible between the compartment 1 extensors and the compartment 2 extensors. The third transducer position of the wrist protocol is scanning the third extensor compartment containing the extensor pollicis longus tendon. So this compartment only contains one tendon. The patient is sitting on the other side of the table, palmar side of the hand flat on the table, and the sonographer palpates for the radial tuberosity or lissus tubercle. The transducer is placed in transverse on top of this tubercle. In the middle of the the screen, the arrow indicating is lissus tubercle, or the radial tuberosity. And then if we sweep the transducer a little bit to the ulnar side, then you can see one tendon in this little groove, this sulcus, and this is the extensor pollicis longus tendon. The tendon, of course, also has a tendon sheet which is here, and make sure that the tendon is nicely hyperechoic. So it's possible that a person does not only have one lissus tubercle, or that there is a little sulcus here. Sometimes this may be a real groove with two very prominent tubercles. This tendon is also being followed a little bit to proximal. You can already see the muscle tissue getting bigger, right? And now going to distal, the muscle tissue getting smaller, and now it's only tendinous. If we follow the compartment 3 tendon, the extensor pollicis longus, to distal, you will see that it will start changing to the other side, to here. And this is again a friction between the extensor pollicis longus crossing the extensor carpi radialis brevis and longus. So this is also intersection, but then distal from the lissus tubercle. The other one is proximal from the lissus tubercle with compartment 2 and 1, and this one is distal from lissus tubercle. The fourth position of the RIS protocol is scanning the fourth extensor compartment, containing several tendons, for example the extensor digitorum communis, but also the extensor indices tendon. The patient is still in the same position, and the lissus tubercle is still the landmark where to place the transducer. So again, the transducer is placed over lissus tubercle. Okay, lissus tubercle now in the middle, here. Then we can see the third compartment, and then the fourth compartment is actually this compartment here. Let's say on the flat part of the radial bone. We can see several tendons, the digitorum communis and also the indices. And all these tendons are within a retinaculum, a tendon sheet. So we can also observe them dynamically, so we can ask the patient to slightly move and extend and flex the fingers, yes, and now you can see them rotating and moving within their compartment. The fifth transducer position of the RIS protocol is scanning the fifth extensor compartment, containing the extensor digiti minimi, or also commonly known as the extensor digiti quinti. The hand of the patient is again in the same position, and now we don't use the lissus tubercle as a landmark, but we take the styloid process of the ulna as a landmark. So let's palpate this round prominent bone of the ulna, and then we are going to place the transducer right on top of it. So in the middle, the ulna, and what we can see actually is now in the middle of the screen, we can see the joint between the ulna and the radius. So this is the distal radio-ulnar joint. Right on top of the joint, superficial to it, we can see a tendon. So I suspect that this is the extensor digiti minimi, the fifth extensor compartment. To be sure, we can ask the patient to extend his little finger, and yes, we can see action of the tendon here. So we can see a rotational movement of the tendon. So that is a confirmation that this is actually the fifth compartment. That's okay. So from here you can follow, like with all the extensor compartments, you can follow the tendon a little bit more to proximal. So this is the extensor digiti minimi, but we can also follow the tendon more to distal. So this is really important to always scan a few centimeters to proximal and a few centimeters to distal. The sixth transducer position of the wrist protocol is scanning the sixth extensor compartment, which contains the extensor carpi ulnaris tendon. The hand is in the same position as also in the previous extensor compartments. Palpate the styloid process of the ulna and the round bone, which is prominent to feel and to see, and place the transducer and transverse on top of this styloid process, which you can see now in the middle. If we follow the contours of this bone really to the ulnar side, you can see a dimple in the bone, and within this dimple you can see a tendon, and this tendon in fact is the extensor carpi ulnaris tendon. Yeah? So this is the extensor carpi ulnaris, and this is the retinaculum and the tendon sheet of this extensor carpi ulnaris tendon. So follow the round shape, and then in the dimple you can see the tendon. You can also test this dynamically by asking the patient to pronate and supinate to see if there is a stability of this extensor carpi ulnaris, which sometimes luxates actually from its place in this sulcus, in this groove. The seventh transducer position of the wrist protocol is the longitudinal scapholunate ligament. The patient has his hand flat on the table, and the sonographer places a little pillow or towel underneath the wrist so that we have a certain degree of movement in the wrist joint. The lissus tubercle, the radial tuberosity, is again palpated, and the transducer is placed on top of it. So now we can see the lissus tubercle here. If you see the lissus tubercle, what we do actually is sweep the transducer to distal until you see the first two carpal bones, which is the scaphoid and the lunate bone. And in between the scapholunate joint, you can see actually the ligament, the scapholunate ligament, longitudinally scanned. So to test if there is a certain stability in the scapholunate joint, or if the scapholunate ligament is intact, what we can do is bring the hand of the patient, the wrist in the patient, to ulnar deviation. So with ulnar deviation, what you might see is a certain gapping in the scapholunate joint due to insufficiency or a tear of the scapholunate ligament. Another thing that you could do to test the ligament and the stability of the joint is ask the patient to clench the wrist. Yeah. And you can do that a few times, just certain clenching to see whether there is a certain stability. And this looks all good, so there is no excessive gapping, which is good. The eighth transducer position of the wrist protocol is scanning the distal radio-ulnar joint, which you already have scanned during the positions of the extensor digiti minimi, compartment 5, and the extensor digitorum communis, compartment 4. But now we're only focusing on the distal radio-ulnar joint itself. Hands still flat on the table, and using the styloid process of the ulna as a landmark, placing the transducer and transverse on top of it. So now we can see the distal radio-ulnar joint here between the radius and the ulna, and to observe the joint we need to make sure that we are scanning it a little bit more to proximal and a little bit more to distal, and observing for fluid collections, bony abnormalities, or maybe also widening of the joint. Transducer number 9 of the wrist protocol is scanning the radiocarpal and the midcarpal joints. What I will do is I will place the towel rolled up underneath the forearm of the patient and hold the patient's hand. And my index finger is placed in this manner so that I can steer and guide his hand into a dorsiflexion and also into a palmaflexion. The transducer is placed on top of the radius, and what we see now is the radius. Now the arrow is pointing at the capsule of the radiocarpal joint, because this is the first carpal bone, the first row, the proximal row. This is the radius, hence this is the radiocarpal joint. This carpal bone is actually the lunate bone, and then following it more to distal, then this is the start of the capitate bone, going all the way up until here. And this joint between the carpal bone, the capitate bone, and the metacarpal bone is the carpal-metacarpal joint. So metacarpal, carpal-metacarpal joint, capitate bone, sloping downwards to the mid-carpal joint between the capitate bone and the lunate bone. This is the radiocarpal joint between the lunate and the radius. So every joint also has a recess, and these recesses can be filled with fluids from the joint, so make sure that you observe them as well. And don't forget to also scan dynamically, because scanning dynamically can also show the arthrokinematics of the bones itself, and sometimes you can see that fluids are being pushed up and become more visible. Transducer position number 10 of the wrist protocol is scanning the ulnar side of the wrist and focusing on the TFCC, the triangular fiber cartilage complex. This is a meniscal disc between the ulna and the triquetral bone of the wrist. The pillow slash towel is still underneath the forearm of the patient, and I'm going to hold the hand of the patient because I will check the TFCC dynamically. The transducer is placed on the ulnar side of the wrist. So what we see actually is the ulna, the triquetral bone, and in between we can see the radiocarpal joint containing the hyperechoic triangular shape, which is actually the TFCC. Underneath the TFCC in the depth you can see a hyperechoic horizontal line. This is actually the lunate bone, so we're really scanning deep inside the radiocarpal joint. So it's interesting to see the TFCC, what exactly the biomechanics are, the movement during ulnar deviation, radial deviation. So that is actually what I will do. So please observe for fluids, for changes in echogenicity, and also with wrong movement or false movements of the TFCC. Transducer position number 11 of the wrist protocol is scanning the proximal carpal tunnel transverse in short axis. The hand of the patient is being brought into a different position, so from facing the palmar side of the hand downwards, we're going to face it upwards, which reveals the palmar side and the carpal tunnel. And then we're going to palpate for the scaphoid bone and also the pisiform bone, and the transducer is placed over these two landmarks, so the scaphoid and the pisiform bone. So this is the pisiform bone, and on the other side we can find the scaphoid bone. And from the scaphoid towards the pisiform bone, we can see this flexor retinaculum or aponeurosis, this flexor aponeurosis. And this flexor retinaculum is going all the way here to the pisiform bone. And underneath this flexor retinaculum we can see various structures. We can see the median nerve. So it's very superficial in the proximal carpal tunnel right next to the retinaculum, and we can find several tendons of the flexor digitorum. So if we ask the patient to flex the fingers, we can see actually that the tendons are moving. If the tendons are moving, then sometimes you also will see that the median nerve is moving from medial to lateral, from left to right, which is normal due to the neurodynamics. In this case, we don't see it that well, but that's okay. So it doesn't mean that it's directly a carpal tunnel syndrome or a compression, something like that. So this is okay. Down here we can also see a tendon which is in fact the flexor pollicis longus. So this is also being regarded as part of the carpal tunnel. So we have a nerve, the median nerve, we have several tendons, the flexor digitorum, but also the flexor pollicis longus, and that all underneath this flexor retinaculum between the pisiform bone and the scaphoid bone. On top of the scaphoid we can see one more tendon. This is not part of the carpal tunnel, but it's there, and this is the flexor carpi radialis tendon. Transducer position number 12 of the RIS protocol is scanning the transverse distal carpal tunnel. So to do this, we are still in the same position as scanning the proximal tunnel, and we will also start in the proximal tunnel. So I'm going to palpate the pisiform bone again and placing the transducer and transverse over it. I know that this is the pisiform bone, right? With underneath, with the retinaculum, flexorum, and underneath the tendons and also the median nerve. And from this position we're going to sweep the transducer down to distal. So you can see the pisiform bone disappearing, and we're going to search for this. So as soon as you see this bone here, right, this is the hook of the hamate, Hamulus ossus hamati. And this hook of hamate bone indicates the presence of the distal carpal tunnel. So now you can see that actually the flexor retinaculum is much more flat, right, than compared to the proximal tunnel. So let's go back to the proximal tunnel, sweeping the transducer a little bit more to proximal, right. You can see that it is actually quite convex, and the retinaculum is flattening in the distal tunnel. So meaning that this median nerve has less space actually to move, because the distance between retinaculum and carpal bones is much smaller than actually in the proximal carpal tunnel, right? So most compressions also occur in the distal carpal tunnel. So always make sure that you scan the distal carpal tunnel to see whether there is a compression. Transducer position number 13 of the RIS protocol is scanning the median nerve, and we're going to scan the median nerve both in the proximal and in the distal carpal tunnel, but now in long axis longitudinally. So the patient is still in this same position, and we're going to place the transducer longitudinal between the thenar muscles to search for the median nerve. So what we can see now is that this is the median nerve longitudinally. We can see the superficial digitorum tendon and also the deep one. So the flexor digitorum superficialis, the flexor digitorum profundus, and this is the median nerve. So important to scan the median nerve in the proximal carpal tunnel, but also to have a look at it more distally, where you can see more of the compressions. If there is a compression more distally, then you will see a compression and thinning of the nerve distally, but a thickening of the nerve more proximally. So we can also ask the patient to flex the fingers, and while flexing the fingers you can also observe the neurodynamics of the median nerve. So the median nerve here between the hyperechoic epineurium sheaths. Transducer position number 14 of the RIS protocol is scanning Guillen's tunnel or the ulnar tunnel, containing the ulnar nerve and ulnar artery. So the patient is still in the same position, and we're going to place again the transducer over the pisiform bone, now not focusing on the proximal carpal tunnel, but now on the Guillen's tunnel. So in clinical practice, you would actually do these two positions at the same time simultaneously, as it is actually one procedure. So what we see actually is that we can see on the right side of the screen, you can see the ulnar tunnel right next to the pisiform bone. So we can see the nerve. So this is the ulnar nerve. We can see the ulnar artery, and the boundaries of the tunnel actually are the retinaculum flexorum, the pisiform bone, and on top of it is the palmar carpal ligament. So neurovascular bundle is protected at this spot. If we are going to follow it to distal, then you will see that the tunnel is actually disappearing and the neurovascular bundle is becoming more superficial. So we're going to sweep distal, the pisiform bone is leaving, and now actually this is the flexor retinaculum with the neurovascular bundle really superficial on top of the retinaculum. So again, this is the nerve, and here we can see the artery. Right, so follow the neurovascular bundle in the tunnel, but also outside the tunnel. And then you have a splitting of the nerve in various branches, but that is being taught on level 2. Transducer position number 15 of the RIS protocol is scanning the flexor pollicis longus tendon in a transverse way. So the hand is still in this position, and we are going to place the transducer in short axis and transverse over the thumb thenar muscles. So like this. And the flexor pollicis longus is actually really easy to find, as it's very prominent in screen because it's this hyperechoic round shape. Right, so this is the flexor pollicis longus tendon and transverse. Surrounding, we have several muscle bellies, for example the flexor pollicis brevis muscle and the opponens muscles. So these are the thumb thenar muscles. So we can follow the tendon more to proximal, we can also follow it more to distal. So more to proximal, now close to the CMC1 joint, and more to distal, and make sure that the tendon is hyperechoic, so it's really easy to lose it through anisotropy. So if you see, now it's gone, it's mimicking a full thickness tear, and now it's there again. So make sure that you have really perpendicular scanning to scan it optimally without anisotropy. Transducer position number 16 is scanning the flexor pollicis longus tendon, but now longitudinally in long axis. So the same transducer position as in transverse, but now not in a transverse way over the thumb thenar muscles, but in a longitudinal way. So it is maybe sometimes easy to start transverse like this, seeing the hyperechoic round shape of the tendon, and then rotating the transducer to longitudinal like this. Now we can see the tendon hyperechoic, long axis in screen, and we can also ask the patient to slightly flex the thumb repetitively, and now we can see the moving of the tendon between the opponens and the flexor pollicis brevis muscle.